Please be seated, ladies and gentlemen. Good morning, ladies and gentlemen. Good morning. Welcome to UHC Forum 2017 official side event titled Neglected Tropical Diseases Driving Progress Towards UHC. My name is Daisuke Imoto. I am the head of Japan Office of Drugs for Neglected Diseases Initiative, not-for-profit research and development organization that aspires to develop treatments for millions of people across the globe affected by neglected tropical diseases. It is my pleasure to welcome you here and be your MC this morning. I would like to thank you all for taking time in your busy schedules to join us today for this special meeting. First, I would like to take a moment to briefly explain today's agenda. The printed program, this one, which is in your bag that you found when you came in, sets forth today's agenda and procedures we will follow. The meeting consists of 3 parts. We proceed with the official opening soon, then we will conduct 2 panel discussions. Please note that we are not taking any breaks until noon, so please feel free to help yourselves to coffee and tea and pastries that are over there near the entrance. During the conduct of the panels, we intend to take questions and comments from the floor if time allows. I ask that anyone wishing to ask a question use a microphone so that everyone can hear. Now, I would like to start the meeting. To begin this program, we are pleased to have Professor Kono, President of Nagasaki University, to deliver the welcoming remarks. So, Professor Kono.
Excellencies, distinguished guests, ladies and gentlemen, I'm very pleased to welcome you to all these UHC Forum official side events focusing on neglected tropical diseases driving progress towards UHC. As the president of Nagasaki University, it is really my great pleasure and honor to co-organize this meaningful event together with Uniting to Combat NTDs, St. Luke's International University, and DNDi Japan. At the beginning, let me introduce our special guests from this event. His Excellency, Dr. Bahar Idris Abu Garda, Federal Minister of Health of Republic of Sudan. Dr. Tedros Adhanom Ghebreyesus, Director General, World Health Organization, is expected to join us later. Dr. Tim Evans, Senior Director of World Bank Group. Mr. Mark Sussman, Chief Strategy Officer and President of the Bill and Melinda Gates Foundation. Ms. Kelly Saldana, Director of the Office of Health Systems, USAID. Mr. Haruo Naito, Representative Cooperative Officer and CEO of the Eisai Corporate Limited. Professor David Molyneux of the Lymphatic Filariasis Support Center, Liverpool School of Tropical Medicine. Dr. B.T. Slingsby, CEO of the Global Health Innovative Technology Funds. Mr. Hisakazu Hiraoka, Advisory Human Development Department of the Japan International Cooperation Agency. And we also have two distinguished guests from the Japanese government. Professor Keizo Takemi, member of the House of Councillors of Japan, and Yasuhiro Suzuki, Vice Minister for Health from Ministry of Health, Labor, and Welfare, Japan. Thank you very much for taking time out of your busy schedules to attend this event. We appreciate it so much. This event is organized as a celebration of the fifth report of the London Declaration on NTDs at the first part, and as a launch of the Japanese network of NTDs to unite the global NTD control activities at the second part of this event. On the occasion of 5th anniversary of the London Declaration for combating NTDs, I would like to appreciate all efforts dedicated by international NTD communities and the World Health Organization, who have treated 1 billion people for neglected tropical diseases in a year. This is an amazing achievement that will continue to increase. But I do hope the number of people who need drugs will be gradually reduced as we strive towards the day when all NTDs are eliminated from all countries and regions. The second part of this event will focus on NTD networking in Japan. Currently, Japanese government and funding agencies are supporting NTD research in endemic countries. To enhance the effectiveness and efficacy of Japan NTD-related technologies and research outcomes in such countries, the Japan NTD network must be established to connect Japanese government agencies, private companies, academia, and public sectors with the WHO and other international NTD communities, such as Uniting to Combat NTDs. We look forward to sharing of many thought-provoking opinions and discussions. We hope you can interact with fellow colleagues as well as establish the relationship that will foster a stronger coalition to combat NTDs and to achieve universal health coverage. I really hope that you all will enjoy this historic event in Tokyo. Thank you.
Thank you, Professor Kono. Moving right along, it is now my pleasure to introduce our distinguished guest speaker, Professor Keizo Takemi, to deliver an official opening of the event. Professor Takemi is a member of the House of Councillors and chair of the Special Mission Committee on Global Health Strategy at the Liberal Democratic Party. He's an internationally renowned advocate for global health issues. Ladies and gentlemen, please join me welcoming Professor Takemi.
Good morning. Your Excellencies and the distinguished guests and gentlemen. I love Nagasaki University very much indeed. Because not only the Nagasaki University has leading the medical school, but also the Nagasaki University has consistently committed on the neglected tropical diseases in the developing countries. Not only Nagasaki University has a lot of branches in the developing countries and directly committed on those, the program on the neglected tropical diseases. This is quite exceptional in the Japanese university. And then the neglected tropical diseases no more than neglected. You remember that the Ebola outbreak happened in the Western Africa. The policymakers of the other side of the planet recognized that the infectious diseases become their own concerns in order to protect their own people. So it's totally changing. And then the Japanese government became involved in the field of the global health in a major way through the G8 in 2000 as a host of the Okinawa Kyushu Summit, and also G8 Toyaku Hokkaido Summit in 2008. And then the last year, the G7 Iseshima Summit in 2016. And in 2008, in 2000, when we was the host of the G8 in Okinawa, our government proposed the Okinawa Infectious Disease Initiative and pledged the $3 billion, which brought about the establishment of the global fund, fight against HIV/AIDS, tuberculosis, and malaria. And then in 2008, when we was a host of the Hokkaido Toyaku Summit, I was asked to be the head of the task force for agenda setting, specifically for the global health by the then Prime Minister Fukuda. And then we did realize that health system strengthening became the other very important approach to tackle on those not only the tropical diseases but also non-tropical diseases, but also the other chronic diseases as well. And then we could successfully mainstream the health system strengthening as the key approach for the global health policy making. And then I would like to recall what happened to the G7 Iseshima Summit last year. We did realize that both the horizontal health systems approach and the disease-oriented, the vertical approaches both. And we should combine those two different approaches in order to create most effective the policy making, which can deliver the real services to the people who are really in need in a community level, specifically the developing countries. And then we finally and successfully input the universal health coverage as a key concept of our global health policy making in the SDG 3. Now, every policymakers in all over the world recognize that universal health coverage became the key concept of our own policy making in order to tackle on so many the common diseases, including the neglected tropical diseases. And then we do realize that the universal health coverage is the multi-sectoral concept of the global health policy making. Therefore, the health-related field is not only enough to create the new goal of the SDG 3. So we always have to collaborate with the other sectors, specifically financing, in order to create real effective financing mechanism in this global community for the common diseases. And then I'm proud that we have a wonderful officials, not only in the Ministry of Health, but also in the Finance Ministry. They did a wonderful job and had a very serious consultation with the key players of the World Bank, International Development Associations, at the meeting of the 18th replenishment meeting in Washington, D.C., just 2 years ago. And then finally we could build up the consensus on which we could widen the mandate of the International Development Association, IDA 18th. Now we can use the plenty of monies of IDA for the global health. And then we now start to identify and confirm the GFF as a key, the fund for the universal health coverage. But in the gigantic and the bureaucracies in the World Bank, the director of the bureau in charge of the GFF is not in charge of the international development aid. Therefore, in order to overcome the bureaucratic, the jungle, we successfully created new regulation in the bank in which the recipient government, which can receive the financial resources from the GFF, can automatically withdraw the more additional, much larger size of the financial resources from International Development Association. The Japanese government contribute 10% of the total budget of the international development aid. Therefore, I really think that we can and we should utilize at least 10% of the IDA's total budget for health in this global community, which means that at least the $3 billion, the US dollar, which should be the potential financial resources which can be utilized for the global health. And also, I'm very pleased to have the wonderful speech of our Prime Minister Abe yesterday. He quite clearly committed to the global health, universal health coverage, in addition to his very important pledge to $2.9 billion US dollar. Therefore, now we are a start to create new financing mechanism for the global health, including neglected tropical diseases, and also we start to involve the finance ministers in each country to involve them as a champion of the universal health coverage as well. The coordinations, not only at the global level for WHO and the World Bank, but also at the country level. Now we try to have the real good, the collaboration between the health ministers and the finance minister. And also we should pay more attention on the community level coordination. And we should have more effective the platform for the collaboration among the key players at the community level as well. And then we can create the whole process of the global health policy making from the global side and country side, and then the community side. This is the architecture for the global health policy making now we try to do. And I hope today, this very important meeting and seminars for the neglected tropical diseases, you can develop the new approach under the new circumstances. And now, my friend, the Tim Evans just come, and he is a really key person in the bank and how we can cope with those very important issues of the neglected tropical diseases under the name of the universal health coverage. And we have already built very important new financing scheme for research and development, that the GHIT in Japan. And thanks to the Mr. Naito of the Eisai Corporation, he and the BT Springsby did a wonderful job to create those new, quite innovative, scheme of financing on the research and development in Japan. Japan is not always a follower for those things. Japan is leading the financing scheme in this global community to combating on the neglected tropical diseases as well. I'm very proud of it. I really hope that the challenge of us will create really efficient commitment on the global health policy making and deliver the really good services for the people who really in need all over the world. Thank you very much for your attention.
Thank you very much, Professor Takemi. So before moving to the panel 1, it is with pleasure that I make a small announcement. Actually, we have another guest from the Parliament, Dr. Tsutomu Tomioka, a member of House of Representatives from Liberal Democratic Party. I would like to emphasize that he's an alumnus of the Medical School of Nagasaki University. Thank you for being here. Now the meeting will proceed to the first panel. I would like to invite Dr. Julie Jacobson, Chair of the Stakeholders Working Group for the Uniting to Combat NTDs Partnership, as well as Senior Program Officer for Infectious Diseases at the Bill and Melinda Gates Foundation Global Health Program. Julie, please come forward and begin the first panel. Ladies and gentlemen, please join me in welcoming Dr. Julie Jacobson.
Thank you. It's an honor and a privilege to be here and to be here at this very auspicious occasion. And I want to welcome all of our honored guests, dignitaries, friends, and colleagues, and friends that are yet to be made. But I, in particular, want to welcome you on behalf of the people who are not in this room. The people that we are serving through these programs don't get the privilege of coming to this beautiful city with that amazing view. It is an amazing view. And they live in places very different without the access to the amenities that we have here and the great services that we have been discussing at this meeting, the universal health care coverage. So those are the people that we are living in service of, and especially through these programs. And so I want to welcome you on their behalf, because it's in their behalf that this program has been really reaching out and making a difference in those people's lives. We're here today because of several different things, but one of the exciting parts is celebrating 5 years of partnership. This is the 5th anniversary of a very unique and open partnership that brought together a diverse set of partners: pharmaceutical companies, donors, researchers, endemic communities, and NGOs, to align together around a shared set of goals that had been established by the World Health Organization in service of trying to achieve these things for these targets for the neglected tropical diseases. 10 diseases were put onto this list, and over the past 5 years, I think that many of us have been honestly surprised and very pleased with the progress that's been made and the acceleration that all of us working together towards a shared goal have really been able to achieve together. And we'll hear more about this with the launch of the report today. The highlight, of course, is that in 2016, over 1 billion people, that's 1 B, not M, not a million, a billion. That's 1 in 7 people on the planet were reached with treatment that have been provided mostly free from our pharmaceutical partners and with incredible service from the community level volunteers and from the NGO partners that support them. But I'm particularly excited to be here because I am a family practice doctor. That is my background. That's what I bring to this field. And when I come to this, what I see is communities in need of care. And part of my reason and interest in NTDs came from working clinically in Africa, Asia, and Latin America. And what I realized is that you would treat people for what looked like simple infections, and people would not get better. And I did not understand this. And one of the reasons why they did not get better is that they have these parasitic and bacterial infections that are hidden inside of their bodies that are taking away their ability to be healthy and to recover from these infections. And so by fighting these diseases from these people that are beyond the end of the road, we give them a chance to live happy and productive lives and to regain the health that has been eluding them. So I am very excited to be here because I see this as an opportunity. When we think of having reached 1 billion people, the opportunity of taking this platform where we have reached the unreached and seeing how we can use that as a tool to help us in reaching the unreached with more than just treatments for neglected tropical diseases, but thinking of this truly as a stepping stone to universal healthcare coverage. So I am very excited on behalf of my own journey as a family practice medicine doctor to see this through from neglected tropical diseases to universal healthcare coverage. So it's been very exciting to be here as part of this forum. I've been very inspired by the words of Jim Kim in the concept of, from the World Bank, of investing in human capital. I think this is part of our future. And from Dr. Tedros and his encouragement and enthusiasm, telling us that universal health coverage is achievable. And I think that in moving forward, the NTDs can be part of that success and be this opening of a doorway into communities and looking at primary health care not as facilities, but as reaching people in the community. So what do the NTDs offer? We offer partnership, accountability, and a shared vision. And Japan has been a part of that vision from the beginning. So today we will have a panel where we have representative of the different stakeholders that are part of this partnership. But to start us off, I have the honor and privilege of introducing Dr. Tedros Ghebreyesus, who is the Director General of the World Health Organization. We have all had the privilege of hearing him several times over the past few days with inspiring words, and we're very honored to have him here. So if I could invite you to the stage, sir.
Good morning. Good morning. First of all, I would like to thank you for inviting me. This is actually the NTDs where I started my job as a junior public health officer in Ethiopia many years ago, more than 30. And I started with schistosomiasis, schistosoma mansoni, schistosoma hematobium, and so on. And I used to do keto cuts method for mansoni, which is a bit difficult, especially in the rural community when you do that and you say you have a bachelor degree and you graduated from university, and they say, why are you doing this when if you have a degree? Anyway, that's how I started, which was very important, and then migrated to malaria later on, and then from health actually into foreign relations, and now back to WHO. But still, it's not because of my first encounter, but because of the reasons I will outline later on. I believe that NTDs are very, very important part of our fight in the global health agenda. And it's actually an important opportunity for me to also highlight not only the importance of neglected tropical diseases or entities in their own right, but in relation to universal health coverage. Because the reality is that the main reason we are still struggling against this disease is because we have failed to achieve universal health coverage. NTDs affect more than 1.5 billion of the poorest and vulnerable people in 149 countries. These people neither have the means nor access to the health services they need. This causes immense suffering, disability, and blindness, and even kill when left untreated. If we strengthen health systems, expand services, and reduce or eliminate out-of-pocket payments, we will go a long way to making NTDs history. This is what WHO's NTD program aims to do. We have a global population coverage target of 80%. We're making progress, of course. In both 2015 and 2016, more than 1 billion people were treated for NTDs, covering 62% of population in need. We're closing in on the 80% target. And we're seeing results. For example, sleeping sickness cases have dropped by 68% since 2011, largely due to optimal use of existing tools, but also thanks to new diagnostics and mobile units that screen at-risk populations. Achievements like this are thanks to the tireless work of health workers and volunteers. More than 1 million health workers have been trained through cascade training programs. In 2016, USAID funded the training of health workers, helping them perform a record-breaking number of operations for trichiasis. The role of community health workers who have in-depth local knowledge is vital to beat NTDs. These volunteers help establish trust between their communities and the health system. They are perfect examples of providing cross-cutting health services and help to other health programs, such as delivering long-lasting insecticide-treated nets for malaria and distributing family planning tools and vitamin A supplements. This is exactly what we mean by integrated people-centered care. The private sector has also played an important role. Generous donations of medicines from pharmaceutical companies to have given poor people access to treatment without the risk of catastrophic financial loss. Industry partners have committed medicines worth over 17 billion from 2012 to 2020. In 2016 alone, more than 1.8 billion treatments were provided to the world's poorest populations. Last month in Abu Dhabi, we saw the launch of a $100 million fund, which is another example of the global momentum to eliminate two of the devastating diseases, river blindness and lymphatic filariasis, that mainly affect the poor. These are investments that pay a rich dividend. NTD interventions are one of the most cost-effective in public health medicines I apologize. I think there is a the papers are too thin, so NTDs interventions are one of the most cost-effective in public health. Treating NTDs saves lives and avoids the disease and disability that keep people mired in poverty. For every dollar invested by funders, the net benefit to affected individuals is $25. Despite the progress we have made, these mostly communicable diseases continue to cost developing economies billions of dollars annually in lost productivity and reduced global prosperity. The good thing is that most NTDs can be controlled and many even eliminated and eradicated. By working with partners in the global community, we have been able to support 10 countries in eliminating lymphatic filariasis as a public health problem, 5 countries in defeating trachoma, the world's leading infectious cause of blindness, 4 countries in eliminating river blindness, and yaws was declared eliminated from India. Tremendous progress is being made against NTDs, and we expect 30 more countries will have eliminated at least one or more of these neglected diseases. We're also making historic gains against sleeping sickness and are on track to eliminating this devastating disease. And despite challenges in 4 countries, we're confident that we will be able to eradicate guinea worm disease soon. But a partnership is vital. One of WHO's mandates is to work in partnership with everyone on public health challenge except the arms and tobacco industries. I commend the London Declaration Group for their engagement and commitment to support WHO in eliminating 10 of these entities. I also value the ideals and work of the CEO Roundtable, which groups together some of the biggest pharmaceutical companies of the world. This has been instrumental in sustaining the generous donation of medicines from pharmaceutical companies, is helping to scale up the elimination of many entities. To make progress, we must work with transparency and trust. As I have said, there should be no suspicion among partners. Last week, I met the private sector leaders and I reiterated my wish to work closely with the International Federation of Pharmaceutical Manufacturers Association to make medicines affordable and available to everyone. We all have a part to play. Together, we must work hard to overcome this disease of poverty, providing wider access to treatment, and as a way to achieving universal health coverage. For the sake of achieving universal health coverage, let us all intensify our efforts and commitments to eliminate these diseases. Your work is crucial in transforming the lives of hundreds of millions of people. Thank you so much. Arigato gozaimasu. Thank you.
Thank you very much for those inspiring words. We'll now begin our panel, and I would like to start our panel with one of the last groups that was referred to by Dr. Tedros, the CEO Roundtable. I would like to introduce Mr. Haro Narita. He is the CEO of ASI, who has been with us in this journey since the very start. ASI was a part of the CEO Roundtable at the very beginning, and you have been the co-chair of the CEO Roundtable with Bill Gates during the last year. So I would like to invite you up to make some comments. Thank you, sir.
Thank you, Julie. Good morning, ladies and gentlemen. On behalf of Uniting to Combat NTDs, I'd like to announce that the fifth progress report is now unveiled, and the updates information of various disease conditions are reported. And particularly, I'm very happy that this time we have a special message from WHO DG Dr. Tedros, encourage us that the NTD elimination is one of the very important milestones towards universal health coverage and achievements of SDGs. Thank you very much, Dr. Tedros, about that. modern pharmaceutical industry has two missions, access and innovation. And London Declaration announced in 2012 has been providing various opportunities for the industry to fulfill those two missions with completely new partners. You know, they are not business partners. They are mainly public partners or global organization. So global industry has been very excited with these new arrangements. As many people pointed out, amazing volume supply has been achieved in those 5 years. And in 2016, we provided 1.8 billion treatments for 10 NTDs, reached to 1 billion people who need it. Our company, Eisai, has been providing DEC tablets, DHL carbamazine tablets for lymphatic filariasis. In those past 5 years, we produced 1.0 billion tablets and supplied to 27 countries. And we are very happy to hear recently WHO announced, validated that 10 countries has been eliminating this devastating disease of LF. That's a very good news. One point I like to emphasize this morning is the many things has been changed even from the starting of this London Declaration. In those five years, many progresses and many changes happened. For example, LF treatments, now WHO recommending a combination therapy of 3 drugs, namely ivermectin, albendazole, and DEC. So it used to be a combination of 2 drugs or single dosage was the recommendation. So now even the therapy itself has been changed. And to cope with this, ivermectin from Merck, albendazole from GSK, and DEC from us, all 3 companies has been committed to supply necessary volume of the medicine until we remove this dreadful disease LF from this world. So, you know, original timeline was up to 2020 that the London Declaration targets, but now we know we need slightly more time, I hope. So we committed to do our business until the last moment. Also, you know, in those 5 years, we successfully create a simple but very effective diagnostic kit for LF, and that helped us greatly. And you know the organization called SPEN, who has started providing us the information of mass drug administration status by geography, and it's very useful for us to build up the strategy how we provide the drug to which geographies. So those things are not available at the beginning of a London Declaration, and now it's here, there, and quite huge improvements have been made since its starting. Second one, innovation. Now, global pharmaceutical industry is very, very active in trying to develop the drug for NTDs, even malaria, TB. Dr. Tellos kindly touched on Gates Foundation CEO roundtable, and major companies CEOs gather together and constantly discuss the issues and opportunities for the industry to develop new remedies for NTDs. For example, our company is developing the new chemical entity for Chagas, filariasis, and mycetoma. Actually, for mycetoma, we are conducting clinical trial in Sudan now. with a lot of partnership, Liverpool School of Tropical Medicine and the DNDI is our constant partner in the case of clinical developments. Here, Dr. Takemi touched on funding, but we have another issue in front of us. That is the drug regulatory approval for NTDs, because usually the financial returns for those attempts are a little. But currently, the same regulatory requirements we are meeting to get the approval from major agencies. I hope someday soon we like to get priority review status for NTD applications. That includes the WHO pre-qualification assessments. Come to funding, I also like to emphasize a Japanese special case of GHIT. I don't know if BT is here or not, but this is a quite a unique organization, government of Japan, Gates Foundation, Wellcome Trust, and Japanese pharmaceutical and diagnostic industry are co-funding this GHIT. And in those 5 years, GHIT supported 68 projects of NTD discovery and development, including 7 clinical trials. And the amount of funding was over $115 million US. And the group has been, pledged to replenish those funding to after 2018. 5 more years, and we decided to allocate over $200 million US for the next 5 years. So this is a great collaboration of various partners, and I think actually this has coming to have the results. Why pharmaceutical industry is so these days enthusiastic to those activities? Of course, the profits we can get from those activities are very limited, because the lymphatic filariasis medications are all free of charge. For example, we produce the drug using our Indian facility in Vizag, huge volume. However, it's all price zero. Many CEOs now have increasingly think this as not corporate social responsibility or philanthropic activities, but instead it's a long-term investment for the future health. Once people get recovered and joining productive activities, it certainly contribute to the national wealth and creating a healthy middle-income class. That is the ultimate goal of those investments. And also, these days, we are amazingly meet new criteria of investment people into our business, so-called ESG, environment, social governance factor, is a key criteria for major investors to invest. And they're talking, once you fulfill ESG, this is a way to accomplish SDG of the United Nations. Environment, social, and governance is a key element for us to look at. That is the contributing to increase so-called non-financial assets, non-financial capitals of the company. So people are looking at the company more in a sustainable way to longer term. So not just the short financial results, but they are more focused on those non-financial capitals, how we increase that. And NTDs, or global health contribution, is greatly contributing for us to fulfill this new criteria of the investments. So finally, I like to, of course, appreciate all constituencies' efforts. However, we are still on the halfway, I believe. And a lot of improvements is needed so that we could have a more efficiency and effectiveness to our activities. Particularly, I like to ask the understandings and collaboration of endemic countries, governments, and officials. Thank you very much.
Thank you, Mr. Naito. I would next like to invite Ms. Kelly Saldana to join us from USAID. She's the Director of Office Health Systems. She's responsible for the technical leadership and the direction with health system strengthening. So, Kelly, would you please join us?
Thank you. Good morning. I'm really pleased to be here for this launch of the 5th report of the London Declaration. And I'm not going to review some of the statistics which are in my talking points that you've heard of 1 billion treatments, but I just want to take a moment to reflect on how monumental this progress really is. USAID has been supporting neglected tropical diseases for over 10 years, but really the progress in the last 5 years is phenomenal. And it's, I think, due to partnership that is, I think we talked about it, but it's a little underappreciated. Think about 10 different diseases working together. Research, pharmaceutical, private sector, donors working together. Multi-sectoral efforts within countries working together. All of these forces come together to achieve what we've achieved in NTDs, and I think that's unprecedented in the field of global health. And it's really a starting point to learn how we can move forward on the path to universal health coverage, applying some of these lessons learned across other parts of the global health portfolio. Within USAID alone, last year we supported over 390 million treatments across 25 countries. But the more important thing, as our administrator at USAID reminds us, is the ultimate goal of our work is to stop the need for development assistance. And so in addition to the 390 million treatments we were able to provide, we also were able to stop treatment to 198 million people for lymphatic filariasis and 84 million for trachoma. In the last year, Togo has been validated by WHO for the elimination of LF, and Cambodia and Laos have validation for the elimination of trachoma. Currently, 10 additional countries are preparing their dossiers for at least one of these two diseases. So I think it's even more important to reflect on that success. Not only are we delivering treatment, but we're achieving success so that we can stop delivering treatment. I think it's been mentioned sort of the value for money that we achieved through this program. For USAID, the cost to us to support treatment is 26 cents or 63 cents per person. Note that the global progress of providing this is due to the generous drug donation programs, but it is a very effective value for money. And really, plus the drug donations and this low cost, we achieve all of this on less than $200 million a year from the donor community. It's just a fabulous success. The funding gap required for the 2020 goals is feasible because it's a low-cost solution, but it requires the mobilization of domestic resources as well as the identification of new donors. I'd also like to take a moment to reflect on the contributions of our host country, Japan. I think we've heard throughout the last couple of days what a leader Japan is in the global health community and really how they forged the trail moving forward in universal health coverage, but also in neglected tropical diseases. Japan's had a pioneering role in fighting neglected tropical diseases. Just one example is the introduction of the Hashimoto Initiative for Global Parasite Control, which was the first initiative of its kind in neglected tropical diseases and launched during the 1997 G7 summit and formally established in 1998. We're really lucky to be able to continue to benefit from the wealth of expertise and knowledge that the Japanese have on neglected tropical diseases, which, as you've heard already, span both public and private sectors. And we want to be able to continue to benefit from the application of this unique perspective and their leadership. We look forward to continuing the partnership and looking for potential opportunities to expand the implementation. As we continue to push for elimination and control of these diseases of poverty, the meeting this week reinforces the importance of capturing and leveraging the broader impact of NTD programs and contributing to universal health coverage and to the achievement of the Sustainable Development Goals. Thank you.
Thank you. I would now like to invite Dr. Tim Evans to join us on the stage. Dr. Evans is the Senior Director of Health, Nutrition, and Population at the World Bank. Tim, would you like to join us?
Thanks very much, and it's a great opportunity to be here. I just have a number of points to make, which I hope will complement the excellent presentations that have already been made. And I want to bring sort of why is this so important to UHC, the work on NTDs. And I think the first message is really picking up on what my president said last night at the closing session, which is when you look at the importance of some of these problems and see what they mean in terms of people's lives, you have to ask the question, it's not good enough not to do anything or hope that somebody else will do something. There's a need to recognize outstanding problems and mobilize action. And the bank, in 1973, on the invitation from a very intrepid epidemiologist, French epidemiologist who was working at WHO at the time, René Lebert, the bank president, Robert McNamara, accepted an invitation to go to what was then called Upper Volta, or Haute Volta, now currently called Burkina Faso. And he, together with his spouse, visited the river valleys along the Red Volta River, where there was hyperendemic onchocerciasis, or river blindness. And I know a few people in this room have visited hyperendemic villages or places where there's been hyperendemic onchocerciasis, but if those people would be brave enough to raise their hand. I see 1.5. Okay, so now I'm revealing my age because I had the opportunity to work in villages that had hyperendemic onchocerciasis in the last century. But what Robert McNamara did was he actually went to these villages and saw the devastation. And when 30 to 50% of the adult population is either blind or severely visually impaired, you can't help to feel the extent to which this is crushing the life out of households, out of communities, and because of the density of transmission in these focal areas along fertile river valleys, it was causing an abandon of invaluable agricultural land at the time of the Sahelian drought, a time when those countries and communities could not afford not to have access to fertile land. And so McNamara, who didn't have a particular interest in health, was confronted with this devastation. And he turned to his wife, and as she looked at him and she said, "Bob, you have to do something." And out of that came really one of the bank's very first investments in the health sector in 1974, but together with UNDP, FAO, WHO, they launched the Onchocerciasis Control Program. Now, did they know what they were doing? I had the wonderful opportunity to work with a fantastic researcher from from France by the name of Bernard Philippon. And Bernard, in his characteristic, sober and frank and honest analysis, said we had no idea what we were doing when we decided to do vector control, to take planes and helicopters and drop larvicide above the sites that the black flies laid their eggs in rapids of rivers where there was sufficient oxygen for the larvae to develop into flies, which were the primary breeding grounds for the vector of onchocerciasis, the appropriately named Simulium damnosum. And they, however, felt that the magnitude of the problem was important enough that they take action. And that's what they did in 7 countries with the original OCP. They started doing vector control. And as they started making progress in decreasing the numbers of flies and the numbers of people that are getting bitten, and they looked at very elaborate field-based epidemiology across the 7 countries with people sitting at the side of rivers and exposing their limbs and waiting for black flies to come to their legs. And when they did, they'd put a test tube over the black fly to capture it, right? Just think of this. These are people who are on the front lines risking infection to try and get more information about how to control this disease. And after 4 or 5 years, they realized, despite some initial local success, there were these problems where the flies were migrating from other countries outside the control zone. And so there was a process to expand to 11 countries with helicopters and stations positioned all over the savanna and Sahel of West Africa. Logistically, a paramilitary operation in the depths of one of the poorest areas of the world with no real infrastructure. Yet, they were incredibly successful without knowing that they would be. No one had done an RCT on vector control, but they started to see rates of infection coming down. And then in the mid-'80s, Roy Vagelos at Merck made an observation that a deworming drug for dogs actually had microfilariaceid impact. And a few years later, there were trials of ivermectin, and it was found to be effective as a microfilariacide. And then we moved to the first big donation, which was Merck decided that they would give a supply of ivermectin free of charge forever for the control of onchocerciasis. And now we've seen where we are today with so many industries joining in that. So I start with that because in many respects, the institution I work for, I think made an incredibly bold decision to move into this in 1970. They didn't do it alone. They did it with the right partners. And they did it for the right reasons. This was not just an issue of health. This was an issue of development. And they invested heavily in learning and evidence, but they didn't have a well-mapped out plan. But they learned as they went, and they made tremendous progress, such that 40 years later, I can say with some confidence that I think we have successfully eliminated as a global community blinding onchocerciasis. And that's a massive achievement, because one of the things about eliminating and eradicating disease is you have an endless stream of benefits. And that endless stream of benefits becomes invisible to the next generation. It's taken for granted. And just as we face the challenge of eliminating and eradicating polio and next generations forgetting I think we have an important role in public health to identify and celebrate these victories, because the next generations are living the benefit of those investments, of those intrepid individuals who were on the front lines of those systems, who have made those investments and sacrifices for the next generation. So wanted to start there. In bringing the opportunity of this agenda, which has made so much progress, there's still some really important things to identify, and I just want to finish by identifying three. First is on the area of discovery. I think the GHIT here is a fantastic example, but I also want to call out DNDi, Drugs for Neglected Diseases Initiative, that I think are doing fantastic work, and I'm really so excited about the human African trypanosomiasis sleeping sickness trials now for an oral therapy for sleeping sickness. We've had the opportunity, thanks to the Japanese, through a Japanese trust fund at the bank, to support the phase 3 clinical trial that's ongoing now in DRC. And I think if that proves to be as promising as it looks, that will transform treatment opportunities for one of the residual NTDs that has been very, very hard to move the therapeutic opportunities forward. So I think we're very close to a breakthrough, and I just think that continuing to look at how those sorts of breakthroughs can change the paradigm for treatment and prevention is so important. And the mechanisms that we come together collectively to create through GHIT and DNDi are ones that are really expressions of global solidarity, of making sure science serves the greatest needs, even if the numbers affected by those challenges from a global perspective are not huge. Delivery is also another area, and here where I'm just adding to a few comments. I think there's just been tremendous innovation in delivery. First is the integrated delivery, and we've seen all sorts of community-based efforts come together where it's not just delivery of ivermectin, but it's also community-based delivery of all sorts of other needs, which are not limited to NTDs, but are inclusive of other challenges and nutritional supplements, micronutrients, and then treatment of other illnesses like TB. So I think that's one area, but also different platforms, the school-based delivery. So we're not necessarily in the healthcare sector, and also regional approaches where you can draw on the regional scale efficiencies in delivery systems. And then new cadres, new types of workers that don't come out necessarily of the traditional clinical disciplines. And I had the privilege and honor of working with a community ophthalmic nurse in Tanzania in the mid-90s who was working on trachoma control in Dodoma area of Tanzania. And this nurse, whose name is Sidney Katala, he's one of my public health heroes, because he alone probably saved 25 or 30,000 people in his lifetime from blindness. And he did it by performing a simple surgery which averts the eyelid called a trichiasis surgery, and did that every day. He did it for cents. If we had a surgery like that, and where I live in Washington, it would be tens of thousands of dollars. And no one really, I think, has duly recognized, in my mind, his enormous contribution. But he did it not because he was looking for accolades and things. He was just committed to the communities that he had the opportunity to serve. And those are real heroes, in my mind, in terms of what's involved in really taking services to the front line and at scale. Last comment on financing. I just want to stress that I think the mobilization of the global pharmaceutical industry, to make these donations is an expression of solidarity that is unprecedented and inspiring. And I think that that should be made clear far and wide, because I think that that's the sort of commitment that we need in taking care of these sorts of problems and making sure that we finish the job. But I'd also like to make a comment that this is also an area where we need to think about two things. One is, in the context of integration, making sure that the community health workers and the financing structures that we're using to support the delivery of these programs are fully integrated into the mainstream of budgeting, such that it's not that we have dedicated workers for an NTD program who are totally financed by an NTD program, and we think that once we achieve an elimination, they're no longer needed. Those communities will find all sorts of needs for those workers, and so the extent to which we can make sure that there are strong bridges with the mainstream of financing, I think will be particularly important. The last point on financing is really just to express the importance of giving value to this endless stream of benefits that's created through eradication. In UHC, we say to prevent and treat and palliate, but we don't talk enough about eliminate or eradicate. And I think in the jargon, as we move forward in building the momentum, we need to give more value to the elimination and the eradication, insofar as the trajectory of benefits and the trajectory of costs for those is very different from ongoing prevention and treatment. And so I'd invite this community to help us articulate how we can more effectively express both the value of elimination and eradication in current reforms to UHC, as well as the value associated with achieving those important objectives. At the bank, we're fully behind and with you on this agenda and look forward to reporting back on greater progress as we move forward. Thank you very much.
Thank you, Tim. I'm not certain if His Excellency, the Minister of Health from Sudan, has been able to make it. All right, he has not been able to make it. He was called into another meeting, and so we were hoping that he would be able to join us for the panel. So I'm going to move over to my colleagues and partners and friends here, and we're going to have a discussion about this and see and talk a little bit more about how far we've gotten and where we're going next. All right. Are you guys comfy? We got the greatest seats in the house here. We get to look at all these beautiful people and that view out the window at the same time. I mean, this is pretty nice. Very inspiring words and perspectives that you've brought to the table here, and so I want to thank you all for that. I wanted to start with a question relating to, in this 5 years, the Uniting Partnership has really grown to be very strong, and it's really highlighted the importance of the role of every single individual and the skills and the strengths that they bring to the table in order to be successful. And I'm wondering, from your perspectives, what have been some of the important or surprising lessons that have come out of this kind of partnership that you've learned as we've taken this journey together? And maybe we'll start with you, Mr. Naito.
Well, we joined this area by the strong recommendation of Margaret Chan, almost threatening us. You should do this, otherwise something else. One surprising one is, we committed to produce 2.2 billion tablets of the DEC at a relatively large size factory in Vizag, southern India, with price zero. But what's happened there is since volume is so large, production cost of that facility gets down. This is a kind of side benefit we are observing at this moment. Also, we used to work together with business partners, of course, Mark or whoever. But now, totally different, value people, public partners, WHO, DNDI, who we have not been seeing in the past. And we learn a lot from them. And particularly, it's quite interesting to work with those public partners. That's amazingly new opening of the era for business like us.
Thank you. What about from USAID? Kelly, any thoughts?
Yes. Yeah. So I think one of the most surprising things to us is the success we've achieved. I think when we set elimination targets in 2020, we were all in to try and achieve them, but we probably thought, well, it's a nice aspirational goal that we'll work towards. But I think the surprising scale that we've been able to achieve by aligning and really coordinating across partners was surprising even to us. I mean, we were thrilled to be in a position where we're now starting to think about, well, what do we do next? And we're going to have to think about control of some of these diseases and how do we do that? And then we look back, and despite the fact that we had designed elimination programs, we think that we've actually had pretty good success in strengthening health systems. And so we're pleased by that and pleasantly surprised as well that as we start moving towards control for some of these diseases, there's a foundation to build on. We have strengthened ministries of health with their ability to do program planning and management for these kinds of diseases, their ability to track the data related to which populations are getting treatment and which are not, and be able to prepare dossiers, and that's really important. And then the training and the involvement of communities, the involvement of schools and educational sector that I think other people have talked about. And so we're surprised by the success, and I think we're also humbled by it and happy that there's a foundation to build on as we start thinking more about what's next and how do we move into control programs for some of these diseases.
Great. Tim, did you want to make any comments on that one? Or
I just think that one of the things I think is so important in this movement is one, the mobilization of knowledge from the bench to the bush, from the back lines to the front lines. It's just a tremendous integration. Which is in many respects seamless. It's come together in so many ways with a strong focus on achieving results. And that's, really brought together, the discovery and delivery dimensions of that knowledge, and also the local to the global. And so I think that is, one of the, to me, the silver linings of this work, because I think that's in many respects what we've got to bring to bear on so many of the challenges that confront us in health.
great. It's my intention to ask one more question to the panelists, and then I'm going to open it up so that folks from the audience can also ask some questions to our panelists. And that question was really focused on kind of looking back, and I'd like to ask a question now, thinking about looking forward. We are looking at 2020 coming to us. We know that we have now goals and objectives to take us through the SDGs through 2030. This partnership has gotten us very far along this journey, and so what are your thoughts about what we need to be thinking about, how we might be related to the SDGs, how we might be thinking about how we come into the UHC goals that have been set out? So what are your thoughts about what we need to focus on as a partnership in the future? And maybe I'll start with Kelly in the middle, and then just to mix things up.
Great, thanks. So, I mean, I think it builds on what I just said. I think, building on the success that we've had, how can we move forward and be a little bit more deliberate? I think, the strengthening of health systems was a bit of a surprise to us. And so now that we know the potential that this program has, and we have these UHC goals, how can we move forward, especially on schistosomiasis and some of the soil-transmitted helminths that we know are going to be more of a control program? How do we get more deliberate about mainstreaming those and integrating them into a universal health coverage agenda? I mean, at the heart of universal health coverage is the concept of equity. I think Agnes told us yesterday it sort of underlies the other goals, and really this program is helping to achieve equity beyond anything else. It's reaching the poorest of the poor. It's treating them with conditions that have spillover benefits into their overall health and well-being, into their ability to learn and go to school, and and has this multi-sectoral thing. And I just think that there's so much potential there that we really need to think strongly how we can harness that to move forward to make NTDs a platform for achieving universal health coverage.
Mr. Naito?
For us, let's say, curing cancer and elimination of one NTD, the value is the same. So now the industry is evaluated by what kind of value you create. So it's great, some of the lung cancer cured now by new combination. But simultaneously, it's great if LF can be eliminated by new combination of the drugs or even the new remedies. So many CEOs are now thinking about that, how we can create value more. And with this regard, NTD and cancer or Alzheimer's are no difference. So fighting, creating medicine to NTD is not something side work for us anymore. It's one of the major battlefields we are working seriously. That's why we like to have something different in terms of our fighting dossier review. Well, let's look at TB drug now. Once we need to develop new TB drug, we need about 5, 6 double-blind trials. In each trials, we need more than 3,000 patients. That's a regular way, but don't you think is there any special clinical pathway to look at the urgency of the drug development for this type, and have some I would not say special, but some different way to review those dossiers. That's something we like to see soon.
Excellent thoughts, and very interesting, a theme of thinking differently and looking at opportunities in which we can move things forward faster with more sustainability and better endpoints. Tim?
Just two things to add on this. First, I think, one of the great health services researchers of the world is a fellow by the name of Tanahashi. And he wrote a seminal paper in the Bulletin of the World Health Organization in 1978, in which he described the opportunity of an efficacious treatment and the challenge of making sure that all those who need that treatment actually get that treatment. And he identified a whole set of bottlenecks related to affordability and accessibility and availability that get in the way. And I think that the measurement of UHC is not the measurement of availability, it's the measurement of effective coverage. It's that those who need the treatment, in fact, get it. 100% of those in need get the treatment, and they get the therapeutic benefit of that drug. So I think This is going to be an incredibly important part of our measurement moving forward, and to look at how, where appropriate, we have either measures of coverage of particular NTDs or proxy measures that would give us an indication of the extent to which we will likely have good, effective coverage of an NTD in a particular area. The second area on the financial protection, there are a couple of dimensions here that I think are really important, and it relates to my own experience working in onchocerciasis, is that some of the impact of these illnesses, once you get them, are lifelong and are disabling. And for those who are blind or who live with conditions that severely limit their mobility or create intense discomfort and joint pain, those are disabling conditions. And there are two things that I think are particularly important on this. One is to look at how well social safety nets support not only the individuals but their families with those disabling conditions. And so I think the area of social protection is a particularly important one. But second, what are the opportunities and investments in rehabilitation and reintegration? Because as I saw when I was looking at the impact of blindness on agricultural production in West Africa in the last century, you have tremendous variation. People who have had an opportunity at rehabilitation, even with significant visual impairment or complete blindness, often can find vocations and opportunities to be active, contributing members to a community. And I think that we should keep that side of the equation in mind in thinking about limiting the negative socioeconomic consequences of people who live with chronic disabling illness.
Thanks, Tim. And I think you've brought some additional layers into this of thinking about how we better target our interventions and how we look at our tools and how we can measure impact going forward in the future, but looking at not just from a disease lens, but from its impact on communities. And I think that's a big challenge for us looking ahead. I'm going to apologize to the audience. I hoped that we would have time for questions from you. I've been given the 5-minute warning, so I'm going to thank the panelists. Thank you so much. And I just want to remark on the fact of from our first conversations when we started this 5 years plus ago, the depth of observation and partnership that's coming through in this conversation is really inspiring. So thank you so much for your time and for being here. So thank you very much. And feel free to step down if you'd like. And I'd like to invite some closing remarks from Mr. Mark Sussman, who's the Chief Strategy Officer and President of Global Policy and Advocacy for the Bill and Melinda Gates Foundation. So Mark, would you please join us on stage?
So thank you, Julie, and thank you to the panel, and thank you to Dr. Tedros and the Honorable former Mr. Takemi and others for their strong and powerful words today. And thank you to all of you in the room. I think events like today's show that while these diseases that we talk about are both still neglected and still have a terrible disease burden in many parts of the developing world, as you've heard, there is a spotlight, there is an energy, there is a momentum, there is a political will, there are a set of partnerships that bring together, if you've seen, academia, the pharmaceutical industry, governments, philanthropists, and others to make sure that these terrible and tragic diseases that do affect so many people really don't have the neglect that we've seen before, and we do take the steps necessary to provide the treatment and provide the care that will help alleviate these terrible symptoms. And it's something that we at the Gates Foundation, certainly pressured very hard by Julie herself and many others, but have been very proud since the original London Declaration, others to be part of. And I think the extraordinary generosity, in this case, of the pharmaceutical industry stepping up with the provision of free treatments and the degree of partnerships with both donors and then the countries, developing countries themselves, is part of what has made us so excited about the continued progress and momentum we're seeing. But we cannot afford to take our foot off that accelerator. That we know, and I encourage that the government of Japan, both by hosting this and the partnership we've had with JICA, who recently attended the event in Kuwait around these things, that Dr. Tedros, who twisted his own travel schedule, which was already things into a little bit of a pretzel, to join us for Reaching the Last Mile Summit in Abu Dhabi a couple of months ago with Bill Gates, is all around how we can keep providing the energy, bring in new actors, bring in new partners around trying to drive this momentum forward. And again, all of you in the room are part of a movement to help us do this. It's something that is seeing tangible success every single day. We think that we need continued partnership and leadership from just about everybody I mentioned. And again, we see particular partnership opportunities with Japan, and Japan is now, through the work of Eisai and others, pioneering Japanese scientists, finding some of the greatest new treatments we have for some of the diseases like lymphatic filariasis and others, which we can expand treatment of in Asia and Africa more broadly. There are also exciting new initiatives like the WHO's ESPEN initiative in Africa, which is now up and running under the inspirational leadership of the African Regional Director. And all of these things together, they are bits and pieces of steps on this coalition that have been building since that London summit in 2012. But really, they are a framework and a foundation, and more than a catalyst, but less than a solution, if you like. And I think what we want to hope we get out of today, and is both understanding that one critical dimension of the universal health coverage framework that we've spent the last couple of days celebrating and championing, trying to drive towards, is making sure that universal health coverage really does include universal treatment for those most in need for many of these diseases, which are now invisible in countries like Japan or the United States, but still have such a deep effect on the lives and livelihoods of so many millions of people around the world. And so with that, I would really just like to thank our panelists, thank the World Health Organization, thank the government of Japan, and thank all the pharmaceutical companies and the other partners for continuing to join and journey with us on this fight. And we hope that as we continue to report on this in the months and years to come, we will bring you more examples of more good news, more great results, until truly these neglected tropical diseases become eliminated tropical diseases. So thank you very much.
Thank you very much, Mr. Mark Sussman. So that sums up the panel 1 of our meeting. The meeting will now proceed to the second part, which will focus on the Japanese contribution to neglected tropical diseases and UHC. Well, before starting the panel discussion, I am pleased to introduce another distinguished guest from the Japanese government, Dr. Yasuhiro Suzuki, to deliver congratulatory remarks. Dr. Suzuki is Chief Medical and Global Health Officer, as well as Vice Minister for Health at the Ministry of Health, Labor, and Welfare of Japan. He has a professional career at the ministry for 30 years, covering multiple health agenda, including infectious diseases. He also worked for the World Health Organization as Executive Director. Ladies and gentlemen, please join me welcoming Dr. Suzuki.
Thank you. On behalf of the Japanese government, and as an introduction to the following panel, it's my great honor to say a few words excuse me, concerning the control program against NTDs and Japan's contribution. Looking back the history of the G7 summit meeting and Japan's contribution to it, back in 1998 at the Birmingham summit, the Japanese Prime Minister at the time, Mr. Hashimoto, late Mr. Hashimoto, proposed to initiate the parasitic disease control program, which is called Hashimoto Initiative, and which led to the JICA the program in Southeast Asia and in Africa as regards the human resources development. Mr. Hiraoka is here from JICA today. And in the year 2000 and 2008, both are G7 summit meeting hosted by Japan at the southern tip of Japan and northern tip of Japan. The parasitic diseases are referred to either within the framework of infectious disease control or the African development. And last year, 2016, within the framework of the achievement SDGs goal, the therapeutic development of NTDs were referred to. More specifically, as regards the disease-specific program, the LF program, lymphatic filariasis program, like PACL, Monsieur Molyneux is here, and African Guinea worm control program, and Chagas disease control program in Latin America. And both are conducted by the Japanese bilateral or multilateral programs. And back in 2012, together with the UNDP and Gates Foundation and Eisai Pharmaceuticals, we have established the GHIT Fund, Global Health Innovative Technology Fund, of which CEO B.T. Slingsby here. And I think two issues are very important. As regards the NTD control program, not only the very expensive high-tech technology, but also the appropriate technology with affordable costs do exist, and we should take best advantage of it. And secondly, there's always a risk of market failure, because there's no incentive actually for the private pharmaceutical companies to invest more in R&D unless we can provide the proper incentive through perhaps pull mechanism, the governments, foundations, civil societies, and NGOs. So these are the reasons why we should have the network of NTDs. Japan has always been the center of the network for NTDs, and its core was the Nagasaki University, the Institute of Tropical Medicine. And the Professor Hirayama is here from Nagasaki University. I'm very proud that it has been and will be the center of the network amongst governments, academia, and the pharmaceutical companies and industries. As in part one, the 5th anniversary of the London Declaration, I think the global importance of global network has been identified by everybody. And we do hope that in the following session, we do see the importance of the network, creating network and enhancing its capabilities. And we do hope the fruitful discussion in the panel. Thank you.
Thank you very much, Dr. Suzuki. Now we would like to move on to the second panel. I would like to invite our moderator, Professor Endo, who is currently Dean of the Graduate School of Public Health at St. Luke's International University. He worked for Japan's Ministry of Health in policy making for several global issues before becoming professor. He also worked at WHO as director of the Department of Neglected Tropical Diseases. Ladies and gentlemen, please welcome Professor Endo and distinguished panelists.
Thank you, Mr. Imoto, for a kind introduction to all of us. And thank you very much staying with us without any intermission or coffee break. But I think still the coffee is there, so please feel free to catch something, or if you need a toilet, then please go ahead. And compared with the first session, the first part, I think the second, I like to make it a more casual way and feel relaxed. And that's why we employ the style of the so-called Davos Economic Forum meeting style. So I think we can enjoy the interaction while someone is making a presentation. So it is my great privilege and pleasure to serve as a moderator for the second session. In his opening remarks, for the fight against the NTDs, Dr. Suzuki reminded us of the long history of the Japanese government in a leading role at several important international political arenas, such as the G8 or C7 summit meetings, and also in its commitments in the field through JICA's projects or research grants for NTD-related diseases, such as provided by the AMED, new Japanese research grant agencies. The same have been true for the private sector in Japan, such as Eisai, or academia, such as Nagasaki University, and NGOs like DNDi Japan, and private public sector like GHIT. Nonetheless, frankly speaking, compared with other countries or other partnerships, there are not necessarily these activities or achievements are not visible from outside of Japan. Individually, of course, acknowledged or appreciated, but not so much visible Japan as a whole. So following excellent successful launch of the fifth report of the London Declaration NTDs in the first part, in this second part, we will, number one, focus on the Japan's role in NTDs in the future. And second, acknowledging the Japanese contribution to the fight against NTDs. And last, this is the most important point, is discuss towards the establishment of the new Japanese NTD network in order to strengthen Japan's roles in NTD. The time is very limited because only 40 minutes or so. But anyway, with this invited 4 distinguished speakers from both overseas and Japan, we'd like to discuss these issues, starting with the individual brief presentation, 5 minutes or so, and then followed by discussion among the speakers and the floor with time allowed. So for the sake of the saving time, please allow me not to make a detailed introduction of each speaker. So now I'd like to start inviting the first speaker, Professor Kenji Hirayama. He is now Dean, the Institute of Tropical Medicine, Nagasaki University, which Dr. Suzuki has already mentioned. And he served not only for the Nagasaki University, but also he's been one of the members of TDR WHO. So Dr. Hirayama, Professor Hirayama, please.
Thank you very much, Dr. Endo. And I'm Kenji Hirayama, the Dean of the Institute of Tropical Medicine, people call NECCEN, Nagasaki University. And today I'm sitting here as a representative of the Academic Society for NTD Control study. Because last month we had a big symposium in our academic societies meeting combined with the tropical medicine, international health, and travelers medicine in Tokyo. And we agreed that we really need some center or the communication platform to unite the related researchers to make facilitation of the activity of Japan. Like Dr. Endo already mentioned, even for us, we cannot identify our presence so clearly. So the discussion is really successful last month, and that's why we decide to make some of the body. So that is one of the very good chance here, empowered by the big people, including Director General and Bill Gates Foundation, all the the most prominent bodies in international. In front of that place, it's a really nice chance to say our university and our institute would serve or contribute to the center, communication center for the Japanese community connected with international settings. Nagasaki is very famous. The university is very famous, as several people already mentioned. 160 years ago, established by the Dutch medical doctor Pompe, and of course, at that time, infection was really popular. And the most important disease. We produced a lot of new tools, the vaccines, and medicine also. And so we stimulated a lot at the time, and our university is really characteristic for the infectious disease control. Of course, later on we had a big tragedy of the atomic bomb, but the infectious disease were really a priority area in our university. And our institute also have a 75 years history, and we were very big contribution to the filariasis control in Japan. Until 1960s, we declared eradication of the filariasis in whole country, including Okinawa and Southern Islands. So that was a really historical achievement in our university and also in our Japanese society. And we appreciate still. We just remembered one thing, is community involvement. And between the university, academia, and the community work together very hard. So that is one of the miracles in our country. So then we just try to expand such strategy to the World Health. And Dr. Ichimori is here, and she is one of the inheritors of our filariasis control and schistosomiasis also control, and soil transmitted hermetic disease also almost eliminated and eradicated. So that is really unique. And school-based medicine is one of the very much successful history in our country. So, but after that, the researchers were somehow neglected for many years. And but after the NTDs movement, after the 2012, and we had a spotlight again. And we're very happy that we survived such period. And now it's time to make such a, the function. And because we have a lot of inheritance. And now it's time to contribute more to the global society to make the world healthy. That is the really, for me, it's a good opportunity to declare such things. And hopefully this time is for Japanese society, it's a very historical and memorable time. Thank you very much.
Professor Hirayama, thank you very much for your strong commitment and with the background why Nagasaki University will be committed to this network. And also he touched upon the importance of the community involvement which related to the universal health coverage. So we don't forget about this importance of network should be under the universal health coverage. Okay, now let's move on to the second speaker. I'd like to invite Mr. Hisakazu Hiraoka, Advisor, Human Development Department, Japan International Cooperation Agency. Before assigned to this current job, he worked for the WHO Western Pacific Regional Office as an EPI program officer, and also he was teaching at Nagasaki University. And the JICA's project have already been mentioned by Professor Takemi and Dr. Suzuki and by the many speakers. But anyway, I'd like to ask Mr. Hiraoka again to mention about JICA's commitment in that sense.
Thank you very much, Dr. Endo, for your kind introduction, and good morning and ohayo gozaimasu to everyone. Today, and also thank you very much for Dr. Hirayama for the strong initiative to take to have a partnership program together with the Japanese societies. So to make a partnership inside Japan, I think it's the first step to introduce what the JICA is doing in the past and also how we are working in the NTD. So I want to start from the introduction of the JICA activities in terms of the NTD control program. Then, first of all, who we are. The Japan International Cooperation Agency, or JICA, is that bilateral ODA implementation body of the Japanese government. ODA is at the official development assistance. So we are supporting the development in the other countries. And we are working over 150 countries each year, and we have nearly 100 overseas offices. So as a center for the contact to each country, we are utilizing these offices to have a discussion with the government, especially in this field, the Ministry of Health. Then what we aim is that our mission that the JICA will work on the human security and also the quality growth. Quality growth is economic growth and social development, but I think one of the terms that you may not be familiar with, that human security. That human security is the concept that we put the people at the center, then we will seeking for the lives of the people free from want and free from fear. The fear includes like the infectious diseases. So the people are fearing for the diseases, especially the communicable diseases that can affect the health of the people. So we are struggling to achieve the lives of the community people to have the healthy living in the community. And why we do the neglected tropical diseases, like as mentions that the NTD is one of the fear to the persons living in the community in the worldwide. So once we get out from this hotel, then we will ask then the persons in Japanese people, do you know the leishmaniasis? Do you know the filariasis? I don't think not so many people knows about it. Filariasis is, I know the filariasis is the diseases my dog has. That is the answers that I can easily expect. But in the reality, in the endemic area of the countries of the NTDs, that these diseases are very close diseases, and they are facing that threat. So we need to remove that threat from these people living in that areas. So once we go to the Bangladesh in the endemic area of the visceral leishmaniasis, they are afraid about that disease. Almost all people knows about the heaviness and also threat of that diseases as Kala Azar. So we need to remove that kind of threat from these peoples. So that's why we are implementing the cooperation in that areas and countries. Then when and how we have been doing in that, we have already started the NTD program, control program in 1970s. For example, the leprosy program in India, and schistosomiasis in the Philippines, and onchocerciasis in Guatemala. So at those times, our major activity is research. So how we can promote the research, then that is our main program. But gradually, our activities shifted from research into the interventions and the control programs. As Dr. Suzuki mentions in the Hashimoto initiative, promoted not only the researches and also the activities to control the parasitic diseases too. So that is our shift. And also currently, in collaboration with the AMET, another organization of the Japanese government, we are promoting the international joint researches to produce innovative approaches to control or eliminate or eradicate the diseases. So that is our new program for us. Then finally, with whom we are working now is that we are, of course, the main counterpart, main collaborator is that the officials in the countries overseas. That is the main partners. But JICA cannot do anything without the help from the other partners, like the academic institution, like Nagasaki University, and also other private companies, and also development consultant firms, and also the bilateral cooperation agencies like USAID, and also multilateral development banks, and are quite supportive to collaboration with our activities. So that's why I acknowledge this support from these organizations, and also I put a stress on the networking among the Japanese society to cope with the, and also collaborate with these stakeholders. And thank you very much for kind attention.
Thank you very much, Mr. Hiraoka, for your overall introduction of JICA's activities in the NTD, especially from the viewpoint of human securities. Yeah. And then the next speaker is Dr. Slingsby from GHIT. I don't think we need to introduce him, but I think from time to time, I think his name was mentioned. But before joining GHIT, Mr. Dr. Slingsby was working for the Asia company. So the former boss is in front of you. So you must be very nervous, but the floor is yours.
Thank you for underlining that. Yes, yes. Well, my former boss and mentor is sitting right in front of me. Yes, yes. So without any increased pressure, today is a very special day for me. I think that looking back when there was the London Declaration, I think that was a good starting point and a pivot for us as a community of neglected tropical diseases. What the London Declaration did is really set goals and got everybody on the same page in terms of where we're headed and what we're trying to accomplish. In terms of whether it was eradication or elimination or control of these diseases, it really set up the goal of what we need to conquer. It also allowed us to identify the gaps that we need to fill in order to reach that goal. It provided a roadmap and allowed us to look at where we are on that road and how we're going to get to that final goal. And that, I think the medium of doing that, the vehicle in terms of reaching that goal, is going to be through partnership. Whether it was the discovery of new technologies or innovations, whether it was the delivery of new product or the development of new products, or the delivery of new medicines or diagnostics or potential vaccines, regardless, discovery, development, or delivery, it was going to be through partnership that would allow us to accomplish that. And it was within that context in which GHIT was born. If you look at the potential innovation in science here in Japan, it's enormous. Look at the number of Nobel laureates that come out of Japan, or the number of peer-reviewed articles for science, both #2 in the world. In fact, in terms of pharmaceutical development, if you look at the number of drugs that have been discovered and developed here in Japan, again, #2 in the world. And it was a matter of breaking into that in order to bring that to the forefront of neglected tropical disease. So GHIT is just merely a catalyst. That's all we are. We're a catalyst for partnership, for the discovery and development of new technologies for neglected tropical diseases and other infectious diseases. We're merely a catalyst. And through that catalyst, we've been able to facilitate these partnerships for the development of new potential products. We facilitated and funded over 60 investments to date over the last 4 to 5 years. And all of these are with Japanese institutions. All of these are using Japanese innovation and technology and capacities and capabilities in pharmaceuticals for neglected diseases. That's precisely our mission, our vision, to catalyze these partnerships. And through that, you're looking at products actually being advanced in our portfolio, from discovery to preclinical to clinical. And just to mention a few of the projects, we have currently 7 clinical trials going on throughout the world with partnerships between, for instance, D&DI and Eisai, or MMV and Takeda. or Nikken and VLP based in Maryland. These are all partnerships that are driving forward this innovation, and within the next 5 years, you're likely going to see 2 products come out of GHIT for these neglected diseases. So I think the model is working, and I'm glad to be part of this entire community of really achieving this goal of the London Declaration, achieving the goal of eliminating these diseases through partnership. Thank you.
BT, thank you very much for your excellent introduction. I'm sure that your former boss is very much proud of your achievement. Okay, last not least speaker, the Professor David Mourinho. He is currently the Senior Professional Fellow and Emeritus Professor, Lymphatic Filariasis Support Center, Liverpool School of Tropical Medicine. But many Japanese may be aware that, well, he has been involved in the Hashimoto initiative, and the Japanese government got advice from him. And since then, he's been involved and watching the development of the Japanese initiative in this field. And also, he is one of the leading, what shall I say, member of the development of the concept of NTD. You remember 13 years ago, we had in the meeting in Berlin, and we launched, like today, the concept of NTD. So I'm sorry, so lengthy introduction that David, the floor is yours.
Thank you. Thank you very much, Hiroshi. It's a real privilege to be in Tokyo, my first visit to this very beautiful city. But thanks to those people who've enabled me to be here, particularly in the context of launching the 5th report and showing the progress that has been made since 2012 in making products available to the poorest on the planet. And also for the epidemiological success which has been demonstrated by some of the verification of the absence of transmission and certification that has been alluded to in several countries. In saying thank you very much for the invitation, the brief I was given was to try and elaborate on the development of partnerships in the context of the experiences that we've had in the UK in particular in trying to advocate for the NTDs and greater investment in what I personally believe is one of the cheapest and best buys in terms of dollars per health gain there's ever been. It is incredible, and I think somebody mentioned it, $17 billion worth of drug given free since 2012 alone. That gives enormous leverage, and our thanks as a community to the pharmaceutical industry for that contribution. But it's really important to see that in the context of what it buys in terms of health for those populations. Now, as Dr. Endo has said, it was a very famous day in Berlin, actually, because I think it was about the 15th of April 2005 that Asamoah Ba, Lorenzo Savioli, Dirk Engels, and myself ended up in Berlin airport, and AB, Asamoah Ba, became the Deputy Director General, said, I'm going to start a department of neglected tropical diseases. You, Hiro, were the first director of that department and deserve enormous credit for the initiation and the vision which the NTD department has become and what it spawned as a community over the last 15 years. But in reflecting on this, I think what has been needed is advocacy for a belief in what we have and what we can do. And that advocacy comes from various levels. And I think that the first example of advocacy for me was Jimmy Carter, who started a mission because he saw guinea worm and the real issues that poor people suffered from having guinea worm, where their communities were transformed. And our colleague from JICA made a really important comment: human security. The human security which was impacted directly by guinea worm was because the disease in Mali is known as the disease of the empty granary, because people could not harvest their food when those communities were completely affected by guinea worm. But since Jimmy Carter became involved in guinea worm, the numbers of people afflicted has gone from 800,000 a year down to 25. Now, whilst we want to see the disease eradicated, there are millions of communities across the planet who will never suffer from this condition. So advocacy is the key, and the maintenance of the advocacy at all levels, be it in Japan or UK, etc., is critical. And on Tuesday this week, we secured the advocacy of probably the best known scientist in the world, Stephen Hawking, who gave his talk for Sight Savers celebrating their billionth treatment. Not a billion treatments overall, but the fact that an NGDO has achieved 1 billion treatments of the products for NTDs during the time that they've been involved. And to have Stephen Hawking talking about neglected tropical diseases is something we should really treasure, because he represents iconic quality science, one of the few people on the planet who can talk authoritatively about billions in terms of galaxies and light years, and also the fact that his father actually worked on DEC in the 1930s, actually in my institution, with a man called Warrington York. Now, the point is there's a continuum of interest here. Now, what I want to go back to in terms of your great initiative here in Japan is you have a legacy upon which you should build and bring together. You've referred to the Hashimoto Initiative, but the fact is that endemic filariasis, schistosomiasis, and soil-transmitted helminths were endemic post-1945 in this country, and you've managed to get rid of them. Now, the parallel, I think, is also the fact that during the period of time since you've got rid of those conditions, actually Japan's economy is one of the sort of great economies of the world. Whether or not anybody's translated the absence of these conditions and NTDs, as well as other broader health concepts, to that achievement, I don't know. But it certainly will have had an effect. And it's been, in South Korea, certainly the impact of soil-transmitted helminths and filariasis control has had an impact on their economy. Now, the point is this, that the legacy you have in the Hashimoto Initiative, the Nobel Prize for Medicine in 2015 with Bill Campbell by Professor Omura for ivermectin discovery, the extraordinary capacity of Dr. Sasakawa to promote leprosy and control and maintain the leprosy community's recognition that you still have a disabling condition out there affecting so many people, despite the fact that in terms of a public health problem, it has declined, really are platforms on which Japan can be extraordinarily proud. And let's remember, and this is where I'd like to thank JICA and pay tribute to Professor Ichimori, the sustained commitment of JICA to the PAC-11 program has resulted in Cook Islands, Vanuatu, Micronesia, and so on, being declared free of lymphatic filariasis within the last year or so. Now, a point I'd like to make about that is that it was a technical achievement achieved with other partners. We had people from James Cook, and we had other pharmaceutical donors involved. But there was that continuity of commitment of the partnership to the PAC-11 partnership, which went from initiation to strategy to eventual success, and the commitment of the endemic countries of the region. That went over a period of 20-odd years. None of these programs are short-term fixes. They have to be seen by the donor community, bilateral donor community in particular, as longer-term aspirations towards elimination, because elimination and eradication take time. So whilst the successes in public health terms, also the availability of the drugs and the access to drugs, it is long-term issues that we have to deal with in that context. Now, I want to come back a little bit to where you might go with your initiative here, Hero. It's about, I mentioned advocacy, local advocacy and engagement by politicians. What we did in the UK was to get a very committed politician who had worked in these environments, Stephen O'Brien initially, to become committed to NTDs. And then we also got the Parliamentary Committee on Malaria to embrace NTDs as well. And these people have regular meetings in the Houses of Parliament, both the upper and lower house, with committed people there. And we have a House of Lords, it may be a bit anachronistic, but we have people there permanently. And it's really important that those individuals become engaged. And we now have Lord Trees, who's a former colleague, who's within that community. So maintaining that momentum. The other thing we have is a UK coalition, which is what you're assembling now with the interested parties like GHIT, JICA, and pharmaceutical industry and academics, bringing them all together. But I think the really important thing is maintaining continuous communication between the partners internally, but also having a brand outside. And Julie's heard me talk about brands. I think the NTD brand has been really important as a brand, because before, and this is what came out in Berlin, nobody wanted to talk about onchocerciasis or schistosomiasis or whatever other ISIS it might be, because nobody understood it. But if you package it as a brand of diseases of the poor, which can be treated, I think this is the way forward. But it's a partnership, absolutely. And there are three things about partnership which I've tried to remember. One, within a partnership, you have to have parity of esteem between all the partners, everybody on the same playing field. The second thing is, it actually costs nothing to give people credit and say thank you and recognize their commitment. But the other thing is, you have to, in managing a partnership, subjugate susceptibilities, because some partners tend to go off course sometimes and don't behave as you might wish them to. But that doesn't mean that they're not still important partners. So subjugating sensitivities is another important factor which you have to take into account. Anyway, those are some initial thoughts, but many thanks again for allowing me to speak and being in Japan. Thank you.
David, thank you very much for your comprehensive presentation. Most of the points which I wanted to discuss after this presentation among the audiences, I think, well, you covered many things. So anyway, time is running short. And then again, could you give a big hands to the presentation of 4 speakers? Thank you very much. Okay, only 10 minutes or so are left for our discussion among the panelists. And then among the several issues which David raised, one of the important issues is that, how to, what should I say, network with the other international networks. Because what is expected of this Japan network is a coordination with other international networks. So from that viewpoint, for example, BT, could you give us some ideas how to what shall I say, maintain how to develop the networks with other international networks, because you have the experience as a GHIT CEO networking. You use the word partnerships, but I think if you have some hint for how to develop this partnership with other international or global partnerships or networks.
Yes, at GHIT we constantly are in communication with a plethora of partners, and it's a full-time job in terms of our organization doing that. But it's absolutely key. If you look at the kind of the global pipeline of NTD's products, there's no one central database of looking at which each funder is funding and which each development partner is funding and or moving on, and what each company is working on. There's no central database to look at this. And the idea of a central database has been coming up for many years now, but it's not in place. And the reasons for that are probably a little too much for the scope of this panel. But the point is with even without that database, it's very key to stay in communication with one's fellow funders, with the various product development partners, with various companies, various universities, and to create one's own kind of almost virtual database by communicating constantly. And that's how we've done it at GHIT. I think moving forward with more and more IT, I think that a central database, a central hub to facilitate that communication is absolutely necessary.
Thank you very much. For example, this session or this year's side event has been well coordinated with the United Combat Against the NTDs. So I think the New Japan Network have to continue to be networking with these communities. And second point for discussion is that about the sustainability of the network. David has already briefly mentioned about this. Yes, people understand, yes, the idea of networking is great, but then it's easy to start, but question is how to maintain or how to sustain. We are very grateful to the Nagasaki University NTD Center. They are committed to, well, become a kind of secretariat or hub of this network. But nonetheless, there must be some tips for how to maintain or sustain the successful, well-coordinated networks. So, David, could you give us some tips? Of course, you have already mentioned, but if possible, could you a little elaborate it?
I think, well, I'll try.
You have the experience in the UK.
Well,
and
yeah, I mean, we started the UK coalition for NTDs, and that was the inspiration of Caroline Harper, because it was about trying to coordinate and communicate amongst the diverse groups who are operationally involved. I think one of the really important things that you need to do is to have some kind of leadership, and a group like that needed a chair and it needed some kind of secretariat support. That needn't be expensive, and I think it shouldn't be expensive, but there needs to be some kind of leader who can also act in an advocacy capacity and draw in the various important elements, not only from the, let's say, the people working at the coalface, and that would be GHIT and JICA, but also that have effective links to parliamentarians, because I think that's where your advocacy case in Japan has got to be sustained. And you try and identify a leader. And I think that when the Global Network was working out of Washington, Julie, they were very good at identifying senators. One of the first points of contact, and I remember this very clearly, Eric Otterson, who's been wonderful colleague and again advocate for NTDs beyond his own Philarasis work, had a meeting in the House in Congress, even before I think the Berlin meeting, and they identified a senator, Tim Leahy, who I think was the Vermont senator, who had a man called who was it? Tim Lee, who's the senator? Anyway, importantly, Leahy, Senator Leahy, his sort of assistant was committed to this. So go to the highest levels and identify people who will work on your behalf. They may have volunteered, or have been Japanese JICA volunteers in their previous history, who understand the countries and the diseases. So it's that sort of thing that needs to be done to start the ball rolling. But leadership, communication, and coordination.
Thank you very much. A very valuable hint. Especially you mentioned about the involvement of parliamentarians. In that sense, we are very lucky. Unfortunately, Professor Takemi left this room, but we had the pleasure having Professor Takemi, and also in that sense, he's very internationally well-known parliamentarian. So I think for the coordination with these other international networks or partnership, I think he must be the key. And also we had the pleasure having Dr. Tomioka, another parliamentarian, and support from the graduate of Nagasaki University. I'm sure that's all Nagasaki University got such kind of very strong, what shall I say, support from the parliamentarians. Okay, only 5 minutes left, and I'm sure that, well, the audience, some of you are very much eager to speak out, because in the first part, we didn't have time to invite any comments from the floor. Do you have? Yes, please. Could you bring microphone, please?
Thank you very much, and thank you for the presentations. The panel before you and this one mentions the issue of community engagement, community involvement. But I don't hear anything about ensuring that the communities, there is community health services. So it seems to me like UHC must invest in community health services establishment, because how do we make use of the communities when they are not there? Like in Africa, if you don't have a community health service, it is very difficult to get to the people with health activities by doing it individually. So what are we going to invest in community health services establishment? Thank you very much.
Thank you very much. Very critical comments. Maybe Mr. Hiraoka, you are in a position to well respond.
Okay, thank you very much for your questions. I didn't mention in my presentation, but we are promoting the community engagement also. For example, we are collaborating with the government of the community, then we promote the community activities. For example, in the Chagas diseases, they need to find out the kissing bag, that is the vector to the diseases to the other people. So we engage, we promote or empower the community people to find out these bags, to find out what is the route of the diseases. Such kind of things we are conducting through the technical cooperation, and also we are sending the volunteers to the other countries. So they are staying in the community and they speak in the community languages. So they talk with the community persons how they can promote and how they can engage in the control of the diseases. So such kind of things we are now promoting. That's the one, just an example, but we are still engaging that community health activities.
Thank you very much. So one more question, yes, from the floor.
Thank you very much. Very enlightening presentation. I'm an anthropologist by qualification, so my question comes from a social sciences background, that what is the role of social sciences in helping us prevent neglected tropical diseases? Particularly, we have a big role by civil society organizations and their coalition in poor countries. Thank you very much.
Wow, thank you very much. But important, but big question. So who will be David? You?
Well, I'm not a social scientist, but I do recognize, and indeed, one of our projects that we have from the UK government, we have got a project called Countdown, which actually emphasizes understanding how communities respond to the problems of NTDs and how we might facilitate better through that understanding the delivery of drugs, particularly the NTD drugs for the diseases that are on the Uniting platform. Because unless we understand how communities react and what they want and how they see, we're never going to reach the end point, because unless communities are prepared to accept the products, and in a sense of that acceptance is dependent on how we interact, or the health workers interact with communities, is really important. But it relates to the previous question. My experience with the river blindness program and the use of ivermectin in that program dates back some time, and the final amount of ivermectin delivered to communities in Africa over the last few years has been 100 million treatments per year. Of that 100 million, 50 million were given to communities who were more than 20 kilometers from any health facility. This is getting beyond the end of the road, far beyond the end of the road. And that's because the communities appreciated the value of that product. Probably the only product they were getting from the formal health services at all, but they were prepared to deliver those products. And the great thing about the communities who received ivermectin, and the same applies to the community-based distributor system, was that 70% of all the drugs approved by the companies and by WHO reached people's mouths in any 1 year. No other program gets anywhere near that. So that's adherence and compliance for quality drugs that actually reach communities who need it. And no other program I'm aware of gets anywhere near that coverage.
Thank you very much, David, for your response. I'm sorry that the VT and Professor Hirayama are eager to respond to the question, but can we? Okay. With the approval by the Mr. MC. So, VT, could you?
Just a quick comment. In terms of the social science perspective, it's absolutely key. From anthropology to sociology to ethics to language is absolutely key. Because regardless of how great of a technology or drug that we develop and that we deliver through partnership and how great finesse that elimination program has, it's up to the individual and the community and the patient or the healthy citizen whether they take that or not. And that decision will need to be informed. And to inform that patient or that person, it needs to be in their language, their understanding, with their understanding of medicine and of healthcare, of public health, in order to do that. So that last step in this mile journey is absolutely key, and that will take social sciences.
Professor Hirayama?
Let me just introduce our new school of the tropical medicine and global health. And that is a 2 years master course and also this 3 years PhD course. And that is the master of public health. And many young generations are interested in such a social science work in the global health area. And lots of projects are going on in the different countries, Bangladesh, India, African countries. And university's advantage is to inherit the younger generation all the the experience to the next generation. So that is really our pleasure to accept such a younger generation.
Thank you very much. Two very important questions from the floor, because this session is, anyway, I'm repeating, under the umbrella of the universal health coverage. So not for the sake of the establishment of the network, but for the sake of the poorest of the poor. So thank you very much for, reminding us the importance of the community, aspect. Okay, while we are enjoying the discussion, and we are started to excited about this communication between floor and the panelists, but I'm sorry that now the time is up. And lastly, I'd like to invite Professor Hirayama for the commitment of Nagasaki University for this network once again.
Thank you very much. In your bag, that bag is also a very rare item now. It's a historical bag, and inside that is this pamphlet. Let me show you this one. And this is our institutional center for the Neglected Tropical Disease Innovation Center, and now we're moving to the Japan Network Center. So, and inside of the pamphlet, you can see a very nice picture of the moving all the activity together, including academia, private sectors, public sectors, and the disease endemic countries. And that cycle should be facilitated to move on by our center in Japan. So please just memorize this date for the big initiation of this center as Japan Network Center. Thank you very much.
Thank you very much for your strong commitment. As you know, this session is being I think everybody in the world is watching through the internet. So anyway, so it's time for the closure of this part, and let me express my sincere appreciation to the distinguished speakers for their great contribution to this session and supporting words. And also let me also thank all the audience for your active participation. I wish all the best for the Japan new NTD network. Thank you very much.
Thank you very much. After you, Brigitte.
Thank you, Professor Endo. Thank you, panelists, for the interactive, encouraging panel. So I would be grateful if you could stay a little more. So now it is time to close the meeting. Okay, so it is my pleasure to invite Professor Ichimori, Professor of Nagasaki University, to deliver the closing remarks. Professor Ichimori is the Director and Lymphatic Filariasis NTD Unit of Nagasaki University's Institute of Tropical Medicine.
Very much. So now we reach to the closing. So closing remarks. I would like to share this closing remarks with Ms. Toko, Puri, uniting to combat NTDs. Because of the core, big and small, yeah. Yes, because we have been working together to prepare this event. Then this is actually it's a teamwork, the real teamwork, and it's a collaboration, right? Great. Okay, I have a lot of lists here, but in short, I just wanted to say thank you very much for all of you. It is a very successful event, and not only successful, but also very much a historical event. Just one highlight, I'm sure the report is already mentioned, but the other one, my understanding from the last session, may I summarize the Japan NTD network is born today, 15th December 2017. Big congratulations. This is a direct highlight. Okay, it's a time to say thank you very much. Thank you very much for all of you. I just want to give it to Toko. Please continue to say something.
Thanks, everyone. I know the other side event, they're waiting outside, but really we just wanted to acknowledge and thank the leadership of Japan, particularly Nagasaki, and we welcome the establishment of the Japan network. On our part as United to Combat NTDs, we will make sure that you're linked in with all of the other networks around the world. And in fact, there is a meeting in February where we're bringing together all of the networks. You're welcome to come and join in that part of the big family. Thank you, everybody, for your attention today, and have a wonderful rest of the afternoon.
Thank you very much.
Thank you.